Hello, welcome to today's video. We're going to be looking at Acute Respiratory Distress Syndrome, also known as ARDS. So what is ARDS? ARDS occurs whenever there's any sort of acute lung injury. And this can be due to a variety of factors. It could be due to some type of physical injury, smoke inhalation, or it can be due to some type of overall infection in the blood that begins to affect the lungs. So the end result of acute lung injury is going to be an increase in vascular permeability. And so when you get an increase in vascular permeability, that allows more fluid leakage, causing edema. And when it gets into the actual alveoli, it decreases the aeration within the alveoli. So we'll begin by first taking a look at the actual pathophysiology of acute respiratory distress syndrome. And so when looking at the pathophysiology, it's important to make a quick diagram. Here is the actual alveola, where the air actually goes through. And then on the left here, this is going to be a blood vessel that I'm drawing. And on the opposite side, we're going to draw the lymphatics. And so all three of these play a role in acute respiratory distress syndrome. And so when we're talking about acute respiratory distress syndrome, one of the main factors that leads to respiratory distress syndrome is going to be fluid accumulating first in the interstitium and then eventually leaking into the alveoli. And so we're going to discuss how this all comes about. So firstly, where does this fluid come from? Well, the fluid comes from the actual blood vessel. So you do have fluid slowly leaking into the interstitium. Now, why is this fluid leaking? Well, the forces that cause it to leak, of course, is the hydrostatic pressure. So you have hydrostatic pressure. However, you do have some forces that prevent it from leaking. And these are primarily going to be the proteins. So this is going to be the proteins in the actual blood. And this helps some of the fluid come back in or allow less fluid to leave. And so when you have a slow leakage of fluid into the interstitium, you begin to collect fluid in this area. Now, it's okay to have a little bit of fluid here, but you definitely don't want any fluid in the alveoli. So how does your lungs prevent fluid from accumulating in the alveoli? Well, we have pneumocytes here. These are epithelial cells. And these epithelial cells have really tight junctions in between them. And these tight junctions prevent fluid from getting inside. However, if there is enough pressure, they can still break through, or if there's some type of discontinuity, it can still break through. So, and then finally, where do all this fluids go? Eventually, if you keep having a leakage and you're not exiting anywhere, of course, it's going to get overwhelmed. So what happens is majority of them go into drain into the lymphatics. So the lymphatics is your final area where everything gets drained off and prevents edema in this area. So that was a normal situation. Let's go ahead and reset the picture here and take a look at what happens when you actually have the pathology. So the first step is you have leakage of the blood vessel. So any pathology that causes spaces to be formed in between the blood vessel can potentially lead to more fluid loss. And so what happens is, instead of losing a small amount of fluid, you end up losing a lot of fluid into the interstitial space. And what also happens is this albumin will eventually go outside as well. And this means that there's going to be less oncotic pressure to help bring this fluid in. So once you have endothelial damage, or not even necessarily damage, but increased permeability, this will not only allow more fluid to leak, but also, because the protons are leaking, less oncotic pressure. And so again, what you'll have is a tremendous amount of fluid accumulating in this interstitial area. Now, normally, of course, your lymphatics can handle an increase in this fluid. And so as long as this amount of the fluid accumulation here does not overwhelm the lymphatics, you can still keep the alveoli dry. But what happens after a while is, when you have way too much fluid, the amount of pressure here begins to overwhelm the lymphatic system, and it begins to draw into the alveoli. And so you end up having fluid here. Now, what does this do to oxygen? So when it comes to oxygen, oxygen is going to have a difficult time firstly going through all this fluid here, and then when you have this edema in this area, the distance between here, the alveoli and the blood vessel increases, and so the oxygen has to go a much longer distance, and you end up having a low arterial oxygen pressure. Additionally, what can also happen is either A, you can get resolution, at this stage, or if it continues to cause diffuse damage, you can eventually get fibrosis in this area. And this fibrosis is due to just because of the inflammatory mediators. And so again, if you get fibrosis, then this tends to get even worse, and it takes a much longer time for the patient to actually get better. And then oftentimes it can also form cysts as it gets two adjoining alveoli become involved. Now, the way I've kind of described it here, you would think that there would be some type of local damage to the blood vessels. And by the way, this can also start from the alveoli side as well, like some type of smoke inhalation. But actually, an increase in inflammatory markers can also lead to this type of scenario. So oftentimes, if patients have a high amount of interleukin-1 or TNF-alpha, which occurs in sepsis, as we'll talk about in a little bit, that can increase the permeability in these lungs and then trigger all of this. Also, neutrophils tend to be really high in these patients. So I'll draw a neutrophil here. And when you take lavages, bronchoalveolar lavages or biopsies, they do tend to have a really high neutrophil count. And this has been attributed to a high amount of interleukin-8. So interleukin-8 gets released in this alveoli here, and that's going to attract a lot of neutrophils into this alveoli. And then obviously neutrophils will again break down a lot of these alveoli and cause the fibrosis. And finally, what also occurs is some of these cells here are type 2 cells. And type 2 cells release surfactant. And so when you get damage to these cells, there's going to be a decrease in the amount of surfactant, and that can lead to alveolar collapse, especially on exhalation. So finally, what are the actual consequences of all this pathology? Well, the first consequence is going to be decreased gas exchange. So as I talked about earlier, because you have so much fluid in this area and you have a widened interstitium because of the fluid in the interstitium, the amount of oxygen that can penetrate into the actual blood vessel is going to be decreased. So in other words, you're going to have VQ mismatch. And so what VQ mismatch means is you're having blood go through here but not become oxygenated. So that's simply what VQ mismatch means. And then it's also known as physiological shunting. So by physiological shunting, again, that means blood is going to go through the lungs without getting oxygenated. And eventually this will lead to hypoxemia, which is one of the presenting signs of patients with acute respiratory distress syndrome. What also occurs is you have decreased lung compliance. And this is attributed, first of all, to the fibrosis that occurs, and also areas where the lung collapses or the alveoli collapses, those areas tend not to expand as well. And so you get this decreased lung compliance. So you have decreased, this is due to decreased areas of aeration and the fibrosis that oftentimes occurs. So that's just a brief idea about the pathophysiology. Now what we can do is we can go ahead and take a look at the actual etiology and what causes acute respiratory distress syndrome. So the first cause that you have is sepsis. Sepsis is by far the most common cause of acute respiratory distress syndrome, and this is especially common in alcoholics. And the reason that it might be common in alcoholics is alcoholics tend to have less glutathione in the lungs, and glutathione is responsible for decreasing the oxidants. So it's theorized that possibly there is more oxidative damage within the alcoholics, and that's why they're more prone for ARDS due to sepsis. Now, another common cause is going to be pneumonia. Pneumonia is a more common cause in patients who are in the hospital, so it's more hospital acquired. And so that's something to keep in mind. So remember, pneumonia can eventually lead to ARDS. Aspiration is another cause. Now, what is aspiration? Aspiration is when you take some type of the normal flora of the upper respiratory tract or within the GIT, and you go ahead and aspirate it into the actual lung. So 1/3 of these are gastric contents, and oftentimes it's associated with a tracheoesophageal fistula, which means a tract that is formed between the trachea and the esophagus, so the food goes directly into the lungs. Severe trauma, so people in accidents and experience heavy trauma can have ARDS. This is generally due to some type of bilateral lung contusion, which again leads to edema. And you also need to remember that long bone fractures can also cause it with the fat emboli. Also, massive blood transfusions. Massive blood transfusions, is, especially when it gets to over 15 units, can be one cause. However, sometimes it can even be caused with 1 unit. So it's not always massive blood transfusion, but it's more commonly with that. Next can be stem cell transplant. We can talk about that. This can be transplant in the lung or bone marrow, and this is generally due to primary graft failure. It takes about 2 to 3 days to develop, and again, it's releasing a lot of cytokines and inflammatory markers into the bloodstream, and that's what's triggering the vasodilation and then the ARDS. There is some drugs that you want to remember. Drugs such as alcohol, aspirin, cocaine and opioids, which are generally misused drugs, and phenothiazines. Now, these drugs here, these 5 drugs, actually occur due to when patients have an overdose. So at usual doses, it shouldn't cause ARDS, but at overdose, they can. Now, drugs such as protamine, nitrofurantoin, and other chemotherapy drugs, these drugs are not necessarily dose dependent. They kind of have more of an idiosyncratic reaction. So depending on certain individuals, they might just be susceptible, and it doesn't have to do with necessarily taking too much. So these are the most common causes. There are other causes that should probably be mentioned. These causes include smoking, patients who have cardiopulmonary bypass, or not only surgery there, but also just thoracic surgery, or if they've had a pneumonectomy, which is another surgery. Remember, acute pancreatitis can also cause it because of all the enzymes that release can sometimes affect the lungs. Obesity, people with blood type A, it's been associated with that, and incidence of near drowning. And this is generally been attributed to the loss of surfactant when the actual water gets into the lungs and they get aspirated. So this is going to be the causes of the etiological causes. So now let's go ahead and change our focus into looking at some of the clinical aspects. So when you're looking at the clinical aspect, it's also always important to remember that there has to be some inciting event that leads to the damage to the lungs, and then about 6 to 72 hours later, the patient becomes symptomatic, so they get some mild symptoms, and then they rapidly become worse. And this is generally described through 3 stages. So the first stage is known as the exudative stage, when you get the actual fluid release and build up into the lungs. The second is going to be the proliferative stage, where healing begins and there's kind of a little bit more of interstitial widening. And then the fibrotic stage is a chronic stage that some patients get into. So let's first talk about the exudative stage. So in the exudative stage, this is going to be the stage that's going to be less than 7 days. And so what happens is you get the actual diffuse alveolar damage, which is caused, and this leads to the fluid accumulation. And that's when all the symptoms begin. So what are the symptoms? You're going to get dyspnea, cyanosis due to the hypoxemia. You also get diffuse crackles because of all of the fluid that's kind of accumulating in the lungs. And as they get worse, they get respiratory symptoms such as high respiratory rate and high heart rate, diaphoresis or otherwise sweating. They start to use their accessory muscles in their neck and thorax. They may begin to cough, and they may even get chest pain. So once the exudative stage is done, you then move on to the proliferative stage. So what is the proliferative stage? So in the proliferative stage, your body the lungs start to heal. Okay, and this generally happens 7 to 10 days after the actual inciting event. So as it starts to heal, you begin to resolve some of the pulmonary edema. So the edema begins to go away, but the job isn't done yet. Now you need to go and fix some of the or accumulate some of the cells that were lost. So you get an increase in alveolar type 2 cells. And so as these cells increase, this can oftentimes lead to a form of squamous metaplasia. And when you have this squamous metaplasia, it releases you get interstitial myofibroblasts for the healing process, and so that can thicken sometimes the interstitium, and so the patient can will still have some symptoms. Of course, symptoms do improve; they will steadily improve, but it won't be as there will still be some there. Now, this only occurs if they don't go into the fibrotic stage. So these are patients who are beginning to heal, but again, oftentimes patients will go from this stage and they will go into the third stage, which is fibrotic. So again, not all patients will go into fibrotic stage, it's only certain patients. And in fibrotic stage, there's so much damage that there's complete obliteration of the normal lung architecture. So it's much more difficult for the lung to heal. And so instead what happens is you get diffuse fibrosis, and in areas where where you have too much lung loss, the tissue loss, you even get cyst formation. And so these patients generally tend to be on long-term mechanical ventilation and oxygen, because it's going to take a while for them to heal, and generally it gets diagnosed with a lung biopsy to confirm that they're in the fibrotic stage and not just maybe a proliferative stage. So this is generally clinically what you'll see. It kind of goes through these 3 stages, or sometimes 2 stages if they're lucky. Now, what investigations would you do? There's a few investigations. The first investigation that you want to do is the ABG. And ABG, the arterial blood gases will show low oxygen, and it will show acute respiratory alkalosis. Also, if you compare it to the arterial oxygen and the alveolar oxygen, there will be a higher AA gradient. So the difference between the oxygen in the arterial and the alveoli are going to be greater. And again, that's just because you have a diffusion issue. Now, you can also do a chest x-ray. Chest x-ray findings are not necessarily very conclusive. 1 second here, okay. So these chest x-ray findings are not very conclusive. What you tend to get is just some sort of diffuse alveolar infiltration, and it tends to be bilateral, so nothing too specific. And so in this diagram that I have here, you can see in this area all over here just some diffuse patchiness, nothing that's going to be too pathognomonic, but definitely tells you that there is a lung issue. And besides that, you can also look, take a look at a CT scan. So in a CT scan, one of the first things you'll notice is there's widespread patchiness. So it's not, like it's supposed to be just nice and black. So you can see the patchiness here, you have some here, and even on the other side you have some over here. So just have that widespread patchiness. And there's also going to be something called an air bronchogram, where the actual bronchi are dilated. So I'm kind of outlining it there. So that's generally what you'll find on CT. So how do you diagnose ARDS? So there is a criteria to diagnose it. The first criteria is that these patients must have respiratory symptoms. So these respiratory symptoms have to occur. So respiratory symptoms have to occur less than 1 week of the inciting event. So any longer than that, and you're going to be doubting the diagnosis of ARDS. Also, on X-ray and CT, you do need to find those opacifications that I showed earlier, so that's necessary. And finally, you need to rule out other causes. The most important cause that you need to rule out is cardiogenic pulmonary edema. So cardiogenic pulmonary edema occurs when a patient has left-sided heart failure, and so then the blood flow backs up, increases hydrostatic pressure, and then it leads to fluid accumulation in the lungs. So it's very similar to ARDS, and so one of the first things you're trying to do is try to differentiate whether you have a cardiogenic pulmonary edema or you have ARDS. So what would help you differentiate that? Well, if it's ARDS, there will be no murmurs. So murmurs are more common, especially S3, S4, are more common with cardiogenic. Also, in ARDS, there will be no increase in JVP, which again will be more common in cardiogenic. On X-ray, if you won't get any cardiomegaly. If it was ARDS, you won't get any venous congestion. That's more common with cardiogenic. And curly B lines are also more cardiogenic. BNP is also a good measure. Generally, in patients with cardiogenic pulmonary edema, they will be raised. But if you have ARDS, less than 100 is more suggestive of ARDS than it is a cardiogenic cause. Also on echo, you should see a normal heart if it's ARDS. And finally, if the pulmonary capillary wedge pressure should also be low. So the pulmonary capillary wedge pressure should be less than 18 millimeters of mercury if it's indeed ARDS. And if it's greater than that, then you're probably thinking more of cardiogenic. So this is just some ways to differentiate. Of course, it's not always 100% clear, so you might need to do other studies, but these are just some that you can do initially. You also need to differentiate it from interstitial lung disease. So interstitial lung disease is a chronic condition, but you want to differentiate it maybe some sort of acute exacerbation that the patient may be having. So of course, history of the disease is going to be a big factor, but if not, even just from the clinical symptoms and on x-ray, you're able to distinguish between the two, but symptomatically sometimes it can be difficult. Diffuse alveolar hemorrhage. So in patients with this syndrome, there will be blood. So they'll have hemoptysis, coughing up blood. Also, they'll have low hemoglobin and low hematocrit because of the blood. And when you do a bronchoalveolar lavage, you'll see some frothy blood. And oftentimes you'll see RBC, of course, and you'll see hemorrhacidin-laden macrophages, which is from the iron that is produced. Finally, cancer. Cancer sometimes moves so rapid that it mimics ARDS, so you do need to kind of keep that in mind as a possibility, but still very unlikely. Now, ARDS can be divided into mild, moderate, or severe. Now, the way you decide which one it is by taking the arterial pressure of oxygen and dividing it by the amount of oxygen that's being inspired through the mask or through ventilation. So, for example, let's just say you have a patient, you check his arterial blood gas, and it's 60 millimeters of mercury of oxygen in the blood. And you take a look at how much he's inspiring, and you see he's inspiring about 80%. So how do you calculate this formula right here? Well, you're going to put the 60 millimeters of mercury on top, and you're going to put the 0.80 on bottom, and you're going to go ahead and divide. And so in this case, it's 75 millimeters of mercury. So this quick formula value that you get here, then you could determine whether you're dealing with a mild, moderate, or severe. So if it's mild, after using this formula, you should get a value between 200 to 300. Moderate, it'll be less than that, 100 to 200. And if it's severe, you'll get less than 100. So in the case of this patient here, he would be less than 100, so he'd be classified as severe. So by taking a look at the amount of oxygen in the blood and the amount of inspired oxygen, you're able to classify the severity of the actual ARDS. And finally, we'll go ahead and look at management. So how do you manage a patient with ARDS? Well, there's three major things that you want to try to do. First, you want to make sure you give them supplemental oxygen so they don't become hypoxemic. Then you want to go ahead and give them support, especially hemodynamic. And then finally, you want to try and deal with the underlying cause. And depending on how severe that is, you actually might want to do that first. So let's first talk about supplemental oxygen. So almost all patients who come with ARDS will require intubation and mechanical ventilation because the amount of hypoxemia is going to be very severe. Now, the way that is done now is called low tidal volume ventilation. So when using this system, you're trying to prevent any type of ventilator-induced lung injury that may occur. So now, how can this occur? Well, sometimes when patients get too high of a tidal volume, this can lead to alveolar overdistension and then suddenly lead to collapse of the entire alveoli, and eventually that can lead to damage. So by using a low tidal volume, you're not distending the alveoli so much and you're not collapsing it so much, so you can prevent that type of damage. So overall, when it comes to steps and all these things, you're not going to need to know this too much detail, but you should just have some idea that you need to keep this patient ventilated as quick as possible. Next, you want to give some supportive type of therapy. So sedation is important. So why do you want to sedate them? This will increase the tolerance to the actual mechanical ventilation. Also, because they're sedated, they have less oxygen consumption, so they won't need that much mechanical ventilation. And the drug of choice oftentimes is lorazepam, especially if it's long-term. Paralysis, you might want to do that if sedation is inadequate, and you want to use some type of neuromuscular blocker, and this can help oftentimes. Opioids also help in pain relief. This can help relax the patient. and you want to use maybe fentanyl and morphine. And relaxing the patient is important because that can decrease a lot of the tachycardia that they may have and some of the higher oxygen required that may be required after that. Next, fluid management is very important, and this is because they do have fluid in their lungs, so you want to make sure you get rid of that. So what your goal is to decrease the left atrial filling pressure, and by decreasing the left atrial filling pressure, that makes it easier for blood to flow in from the lungs into the left atrium, and that will eventually decrease the pulmonary edema that they have. So that's very important. And you do that by trying to keep the CVP, the central venous pressure, less than 4 millimeters of mercury. But at the same time, you want to make sure you have good organ perfusion, especially the kidneys. So that could be a balance that needs to be done. So, and you achieve this by fluid restriction and by giving them diuretics. So you can try to get rid of that fluid in the lungs. Nutritional support is also important. The patients oftentimes are in a high catabolic state, and so they do have high nutrition requirements. And this is oftentimes the best way to do it is just enteral feeding to, just the best way usually to do these things. Glucose control is also important, as well as DVT and GIT prophylaxis. Oftentimes these patients can get ulcers, especially if they were in a trauma case. So this is kind of the supportive treatments that are available for these patients. And finally, you do want to treat the underlying cause. And again, if it's a really big cause like sepsis, something like that, it might be the first thing you want to treat. And that's because the underlying cause is usually the most common cause of death. Usually patients do not die directly from respiratory failure. So this kind of highlights the importance of actually treating the underlying cause. Now there are some, because it's a very serious condition and with a very high mortality, there are other therapies that has been tried. One has been use of surfactants and antioxidants. Right now there is no evidence whatsoever to do this, so don't do this, I guess. Also the use of nitric oxide, prostacyclin, and prostaglandin. The idea is you're trying to dilate the bronchial airways. However, studies have not shown any improvement in the final outcomes, so it's not necessarily useful at the moment. Also, glucocorticoids, these are commonly used. Now, less than 2 weeks, it's uncertain. We kind of have evidence both ways, but greater than 2 weeks, it's actually been shown to harmful, so it's contraindicated greater than 2 weeks, so be aware of that. Now, human mesenchymal stem cell does help the lung heal quicker, and this has actually been showing some promise. So this actually might be something in the future that we may see being done until the technique is perfected and more studies get done. So this was the topic of ARDS. Hope you learned a lot, and I hope to see you in my future videos. Thank you.